I'm going to get started. If people want to come in and grab their seats, feel free to continue to dine. So I want to begin the lunch symposium. This is a symposium on the use of the JETSTREAM device in the periphery. At the outset, I want to thank Bayer for their sponsorship of this symposium, and thank you all for being here. I've decided to present this as kind of a two-part presentation. The first part, I'd like to just review the device itself so that you have a good understanding of the device, look at the iterations that have taken place since it was introduced, and then review some of the clinical trial data and some of the more recent study data looking at the effectiveness in calcium removal, and look at ways that how this technology can be integrated into your practice. So this is my disclosure. I serve as a consultant for Bayer, and I've worked closely with them and with Pathway over the last few years with this technology and its application. So this is the JETSTREAM device. This is the first commercially available device in 2008. At the time of its introduction, let's see if I have a pointer here. At the time of its introduction, it had a 10-flute design on the cutter, and the device still has the capability in the larger devices of expandable cutter by virtue of the direction of torque. These blades will either be open or closed depending on how the device spins, what direction it spins. From its introduction, the device had as a key component an aspiration port which was integrated into the shaft of the catheter. Originally, this was 8 French sheath compatible. It's now 7 French sheath compatible. The aspiration port was moved with the G2 device proximal to the cutting blades, and in the second iteration, a macerated was added. And with those additions, it really improved its effectiveness in terms of aspiration. And by virtue of that, achieved approval not just as an atherectomy device, but also as a thrombectomy device. It was much more effective in terms of its aspiration efficiency compared to the original device, and really was a significant improvement in the device, and that's continued. The G2 NXT atherectomy device, which was introduced in August of 2009, had some changes in the shaft, PBAC's outer shaft and stainless steel hypotube. That effectively reduced the outer diameter of the shaft and allowed it to be 7 French compatible. And with those changes, really improved the trackability of this device, particularly for using contralateral access. The G3 modification was significant in terms of the cutter design. It changed from the original 10 to a 5-flute design, and with that there was significant improvement in the effectiveness of cutting, 54% increase in torque and power with the device, and allowed the device to perform better in complex disease. There was again improvement by virtue of those changes in the aspiration efficiency as well, though less noticeable. There's some changes in terms of the distal bushing with some of the changes in the drive shaft. That has allowed for greater improvements in trackability of the device. This is an 014 compatible system, and there's been some improvements in user interface with the iteration that took place in 2010. The Navitus device further improved the bushing and distal liner and improved the performance of the catheter on a wire so that there was less binding, a smooth movement, and added protection against thrombus and adhesion as you're using the device. And there were some additional changes in guide wire management, all of which translated to improvements in how the device was using and how the operator interfaced with the device. Further changes in terms of the control pod and catheter designs took place with the SF device, the small fixed device. So this device does not have the expandable blades. So everything else is the same. Aspiration, cutters, and the number of flutes on the cutter comes in the 1.6 millimeter profile and 1.8 millimeter profile, but in the SF platform does not have the expandable blade, so it's a fixed system. It still is 7 French sheath compatible, and this is ideally designed for smaller vessels, ideally below the knee. Still has active aspiration, which is true of the larger device as well. So this was a significant improvement in the spectrum of catheters that we had at our disposal and allowed us to treat more patients in more vascular beds. At the other extreme, the Navitus L atherectomy device, the large device, was introduced in 2012. So 2.1, 3.1 millimeters in the original device. This device in the larger platform is 2.4, 3.4 millimeters, so 30% larger. Some changes in terms of the coupler design it resulted in improvements in performance and tortuous anatomy, but everything else is the same, just bigger device for more effective debulking in larger vessels, SFA, popliteal primarily. So this is a magnified view of the current device in the L platform. It still has the 5-flute cutter design, the expandable blades, the aspiration port, 7 French compatible still, and an over-the-wire system, 014 compatible. Let's move on. I think we've sort of summarized that. So the attributes of the JETSTREAM device, that's true of all sizes, is that this device has effectiveness in a variety of lesion morphologies. Calcified vessels, calcified atheroma, soft plaque, thrombus, chronic total occlusion. It can effectively treat all of those different lesion morphologies. It does that by virtue of the design, the front end cutter, as well as differential cutting, the ability to cut the disease while sparing normal intimal components. Active aspiration is currently a key component of this device. It allows you to aspirate the particulate material that's generated and also allows you to remove thrombus, and therein its approval as a thrombectomy device. The changes that have taken place in a relatively short period of time are really monumental for a device, but the net effect is that it has given us a much higher performance device with greater spectrum of sizes for treating different vascular beds. So we can now treat both small and large vessels, tortuous segments, calcified, thrombus, chronic total occlusions, just about every subset that you'll encounter. It's the only below-the-knee atherectomy device currently that does have active aspiration, and therein lies a key design feature of this device, and it does minimize risk of distal embolization. I'm often asked, as I present on this topic, the need for distal embolization. We'll review the trial data momentarily, but the incidence of distal embolization, recognizable distal embolization with this device, provided that the appropriate technique is utilized, was actually quite low in the trials and remains low by most operators today. There are certain clinical situations where it may be appropriate to use distal protection, extensive disease, with critical limb ischemia, single vessel runoff, particularly if it's diseased infrapopliteal circulation, that would be a good place to use distal protection, where your margin to deal with a complication is so reduced. But basically beyond those subsets, there really is not a need, I think, for distal protection with this device. So this sort of summarizes graphically the different sizes that are currently available, the similarity in terms of the cutter design and the shaft design and profile. All currently are still 7 French sheath compatible. This is the range for the Navitus, minimal vessel diameter with blades down 3 millimeters, with the blades up 4 millimeters, and for the Navitus L, the larger device, the range is 3.5 to 4.5 millimeters. Some recent changes between the SC device and the Navitus device have taken place in the control pod. I'm going to go through these relatively quickly, but all of these changes have translated to a more ergonomically sound handheld device. which either you or your technical support staff can handle very easily as you work with the catheter. It's all integrated. In the activation mode and in the REX mode, those controls are there. And you can also release the control pod if you want to have the handle held on. There's an extension, and that can be easier to use. So simple changes have translated to ease of use and ease of performance. So to summarize the technical changes that have taken place in terms of the design of this device, this is intended for use as an atherectomy and thrombectomy device for the peripheral vasculature. It's not currently approved for use in coronary, carotid, iliac, or renal vasculature. There have been significant changes since its introduction and with the device modifications, I think all of which have translated to enhanced performance, improved safety, and clearly expanded indications by virtue of the larger and now the smaller devices. So let's review some of the clinical trial data that led to the approval of this device in this country, and then a more recent body of data looking at the effectiveness of this device, specifically in calcium removal. This is the data that has been previously published. This is a European trial. This is a one-year outcome of percutaneous rotational atherectomy with the JETSTREAM device in infrainguinal peripheral circulation. This was a prospective, non-randomized trial. It was designed to evaluate the safety and efficacy of the JETSTREAM device for occlusive disease. 172 patients were enrolled. Mean age was 72. 9 study sites, Rutherford class 1 to 5 ischemia. The inclusion criteria were those with stenoses greater than 70%, less than 10 centimeters in length in the femoral popliteal bed, less than 3 centimeters infrapopliteal, with vessel diameter of 3 to 5 millimeters. The exclusion criteria are listed: reduced life expectancy, intolerance to antiplatelet therapy, recent CVA, in-stent restenosis by design was excluded, severe vessel angulation, and really impaired distal runoff. So the study did include predominantly patients in the SFA and popliteal. There was a cohort of patients that also had treatment below the knee. In fact, it was 37% of the original cohort. You can see the distribution: 64% in the SFA, 28% in the popliteal, 9% in the tibial arteries. Lesion length was 27 millimeters. It's important to note that a large number of these patients had really complex disease with extensive calcification. Let me go back. 51% had high calcium. Chronic total occlusions represented about a third of the patients in this early experience. The pretreatment percent stenosis was 79%, following atherectomy, 35%, and then following adjunctive balloon angioplasty, 21%, with a mean percent reduction of 43%. Activation time of the device was about 3.5 minutes. Procedural success was near 100%, 99%. Interventional success the same. Stent usage was discouraged by study design, and provisional stenting took place in 7% of patients. There were no major adverse events at 30 days: death, MI, target vessel revascularization. Two patients did have planned amputation, so a low incidence of adverse events at 30 days. In terms of other device-related adverse events, you can see the distal embolic event rate was 1.7%, dissection less than 1%, no perforations, abrupt closure and target limb revascularization less than 1%. At 6 months, major adverse events were observed in 19% of patients. However, the majority of these, 81%, represented target lesion revascularization, which was 15%. Death and amputation took place 1% each, and non-Q-wave or non-STEMI MI 1%. Primary patency at 12 months, duplex driven was 62% roughly. Secondary duplex driven was 81%. Clinically driven TLR rates at 6 and 12 months were 14% and 26% respectively. In terms of functional data, significant improvement was observed in terms of their ankle brachial index at 12-month follow-up, 0.59 pre, 0.82 post, with a corresponding change in Rutherford class from 3 pre-treatment to 1.5, both achieving statistical significance. More recently, we examined the specific effectiveness of this device in removing calcium. This was a calcium study, which was again a prospective study looking at the device with intravascular ultrasound guidance. This is a single-arm, multi-center study looking at the effectiveness in symptomatic lesions with superficial calcium, which constituted more than 90 degrees arc and more than 5 millimeters in length, as evaluated by intravascular ultrasound. The primary endpoint of the study was calcium removal and luminal gain, as measured by pre- and post-IVUS images, which were done systematically and adjudicated at a core lab. Secondary endpoints were major adverse events, target lesion or vessel revascularization, death, unplanned amputation, or MI, and the use of adjunctive balloon angioplasty and stenting. The Volcano IVUS system was utilized, automatic pullback at 1 millimeter per second, and there were, fairly rigorous places where we imaged both pre and post-treatment so that there was consistency, and then matched IVUS slides were examined at the core lab to evaluate the effectiveness of the device. Let's go back to the end of that last slide. So in this initial review, 21 subjects with available images were included, and we'll examine the data. Let's go on. So mean age of patients was 72, 52% had diabetes. The majority of patients were in the SFA, 76%, 33% in the popliteal, 5% in the common femoral, SFA and popliteal 10%, common and SFA 5%. De novo disease 91%. Calcium was quite excessive, moderate 33%, severe calcium 67%. 55 millimeter lengths were treated. Lesion diameter was vessel diameter was 5 millimeter. The pre-treatment percent stenosis was 82%, and following JETSTREAM device alone decreased to 40%. The run times were 5 minutes, blades down, 2 minutes, blades up, 2 minutes. Volume of aspirate was 200 cc. So these are not long procedures in terms of the device. Having said that, though, it's important that you do not accelerate the use of this device. You've got to adhere to the technical indicators for this device. It's a slow, methodical advancement, a to and fro advancement, rather than just pushing the device through. You've got to let the device do its job. So for this disease that was being treated, these are sort of representative time frames to keep in mind. In terms of adjunctive treatment by design, angioplasty was encouraged to be used after atherectomy, 71%. Stent usage did take place, 24%, so higher than in the original trial. Other modalities, 4.8%. Hopefully you can read that in the back of the room. This is the IVUS analysis. It's broken down to minimum luminal area site and maximum calcium ablation site. And the net result is that you can see significant improvement, luminal gain with the device pre, 4.3 to 7.4 with a highly significant p-value. Percent stenosis decreased from 66 to 35. Again, significant p-value. In terms of calcium removal, if you go down towards the end of the slide, in this small series, 21 patients, there was not a significant difference in terms of the effectiveness of calcium removal to achieve a significant p-value. The trends were favorable. But when you look at the data in terms of the reverberation of the device, on further analysis, there was significant luminal gain even in those patients with high calcification. This is a representative example of a fairly focal SFA lesion with the corresponding IVUS on the bottom. You can see there's a dense calcium improvement in the luminal dimensions after removing the calcium, and then following balloon angioplasty, further improvement in luminal gain, attesting to the effectiveness of the device. In the trial, there were no major adverse events, no deaths, MI, unplanned amputation, or target lesion revascularization. So this study did corroborate the effectiveness of this technology in improving luminal dimensions based on intravascular ultrasound analysis, which was systematically applied and tended to show favorable results with calcium removal. So how to summarize this technology, how to sort of integrate this into your practice? This is unquestionably an effective and safe debulking device and aspirating device. It allows you to treat multiple disease states in the femoral popliteal as well as below the knee. It effectively removes calcium. It aspirates thrombus. It'll treat soft plaque, eccentric disease, concentric disease. It really doesn't make any difference what disease state you're treating. The most important thing is to select the appropriate size device and adhere to the proper technique. Let the device do its job. There's no question that the ultimate luminal gain that you achieve with serial IVUS images exceeds that you would predict from the size of the cutter alone. Why is that? It's due to a couple of things. First, the device is spinning at roughly 70,000 RPMs. It does have the property of differential cutting. So it sort of seeks out the disease state and deflects away from normal intimal surface. But a key component to achieve its effectiveness is the aspiration component. If you look at IVUS images for a variety of lesion morphologies, extensive calcium, mixed disease with fibrous disease, or just pure thrombus, you will consistently see improvement in the MLD in each of those beyond what you would predict from the size of the cutter alone, just with the JETSTREAM device alone. And then if you add to that adjunctive balloon angioplasty, there's further increase. So on whole, you can predict about a 45% increase in luminal gain with this device beyond what you would predict from it by virtue of its size alone. This device clearly allows you to expand treatment options for traditionally difficult vascular beds. Where are those? Common femoral, heavily calcified vascular bed traditionally, which historically has been an area that we have not been very effective in treating. And we tend not to stent that. There's so much disease that balloon angioplasty alone is not going to be very effective, and arterectomy has been the treatment of choice. But I believe that this device will allow you to treat that location and that disease site very effectively, and that's how we've approached it. SFA origin disease is another subset which can be challenging, because when you start to treat that with angioplasty, what you don't want to do, especially if it's diffuse disease, is compromise the profunda artery. This device introduces an element of effectiveness beyond balloon angioplasty, limiting the need for stenting in that location while preserving the profunda artery, which is really a lifeline for that patient. Same thing in the popliteal, particularly the mid-popliteal, distal popliteal, where traditionally we like to not stent. This device can also improve the effectiveness as a debulking tool, and then followed by balloon angioplasty. Now, we don't currently in this country have balloons that elute drugs other than in investigational protocols. But in Europe, this is being integrated closely with that technology, and it's becoming a more acceptable implementation of this technology. Why consider this in the SFA? Now, the data that validates this and the use in the SFA is really limited only at this point to limited patient series. The original European data now substantiated by a small series in terms of the calcium removal. But intuitively, this device makes sense. And if you do intravascular ultrasound systematically in peripheral circulation, you will quickly learn the effectiveness of this device. I was originally attracted to this technology for the SFA because it is as challenging and complex a vascular bed that we treat. The disease burden is excessively high. The lesion morphology is complex. Chronic total occlusions, excessive calcium, thrombus, extensive long segments of disease that we treat. Balloon angioplasty has historically been associated with early and late failures. Stenting has its limitation, although randomized trials have shown superiority of stenting versus balloon angioplasty. But metal fatigue, stent fatigue is a reality. Restenosis still exists, and the longer and more aggressively we stent the SFA, the higher the risk of some of those problems. We know the limitations of surgical approach, increased morbidity and late graft failure. So intuitively, this device has some attraction in terms of plaque removal to achieve luminal gain. The other thing that I like about this device, unlike some of the other atherectomy devices, which have their attributes and favorable profile as well, is that we often don't know the true disease complexity that we're treating. If you're not doing intravascular ultrasound up front, and if you're not interrogating this with virtual histology, you really don't know how extensive a disease subset you're dealing with. So, they may look to be fairly calcified angiographically, but when you look at it with IVUS, you may find that the calcium is actually fairly deep, and that there's a significant component of fibrous disease, and some of the other devices don't traditionally perform that well in those situations. By virtue of its design, the ability with the expandable blades, there is some inherent efficiencies of the device. By simply changing the direction of torque, you gain incremental size and profile to allow you to more effectively debulk as opposed to changing to a different catheter. And there's some cost effectiveness in that. It is relatively easy to use. You do have to adhere to a proper technique, but once you've mastered that, it's very easy to use with the assistance of your technical staff. This is an example of a patient that we treated not too long ago, a patient that had a very heavily calcified common femoral artery with pre-treatment intravascular ultrasound with color flow. For those of you that are not familiar with intravascular ultrasound, that central dark circle on the right is the catheter itself. That surrounding area between 9 and 3 o'clock is excessive calcium, another arc of calcium between 1 and 3 o'clock, and then fibrous disease and significant luminal compromise. So this is the kind of patient, you put a balloon in there, number one, you're probably going to have a dissection, which is going to be generated at the edge of the calcium, and you're just not going to be able to achieve a durable angioplasty result with this kind of morphology. This is that patient after we had debulked and then performed balloon angioplasty, and excellent luminal gain. Now, the final cross-sectional area was 12.5 millimeters squared. By virtue of the cutter itself, the predicted size is about 7.9 millimeters squared. So as I said at the outset, about a 40% increase. So this was debulked with the JETSTREAM, followed by balloon angioplasty. We've used this in long segments of chronic total occlusion, diffuse disease that's open, and the technique is to recanalize this using basic angioplasty techniques, subintimal angioplasty. We try to stay as intraluminally as possible. I tend to, after I've recanalized this, rather than going right to the device, I either will interrogate this with intravascular ultrasound after recanalizing it, or sometimes pre-dilate with a very small balloon to create a sort of a small lumen, and then debulk progressively with the JETSTREAM device. So this shows the technique after it's been recanalized. You make a series of runs with the blades down. You have to be attentive to the RPMs and the pitch of the device as you are advancing it. You have to be attentive to the aspirate that you're generating. If you encounter a point where there's very high load on the device and the RPMs drop dramatically, back the device up, advance it more slowly with the blades down to begin to debulk that. Once you've made a series of passes, usually 2 or 3 passes with the blades down, then go back, assess it with an angiogram. If the intimal surface is relatively smooth, you don't have any dissection planes, then you can more aggressively debulk with the blades up. Now, when you go back for a long segment of disease like this with the blades up, you may encounter, again, focal areas where the load is very high and the device drops off in RPMs. Rather than abandoning the device, you have 2 options. You can go back more proximally, blades down, make a few more passes, and then go back with the blades up, or manually advance the catheter beyond that area, and then begin the atherectomy run, again, to minimize any dissection or vessel disruption. And that's the technique that we've utilized. That's followed by balloon angioplasty, and in all of these cases, the final decider is the image with intravascular ultrasound. What are we looking for? We're looking at residual disease burden, we're looking at vessel architecture, and we're looking at luminal gain. Those are the factors that decide, to me, corroborated by the angiogram, whether the adjunctive balloon angioplasty is enough or if we have to stent. Stenting provisionally is acceptable. There's nothing wrong with that. I believe that by debulking this vascular bed prior to stenting is going to optimize stent performance. It clearly is going to optimize luminal gain of the stent, and whether that translates to better long-term result, time will tell. This is the first patient that we treated that had acute thrombosis following stenting of the SFA. This was quickly recanalized with an 014 wire, which is a technical tip-off that you're dealing with a high thrombus burden. And this was treated effectively with the G2 device, followed by low-pressure balloon angioplasty, no distal protection, tremendous effectiveness as a thrombectomy device, and achieved a very satisfactory result. The SF device has really expanded the opportunity to use this in small vessel disease. And this doesn't just have to be focal disease, as you'll see in some of these examples. It can be long segments of complex disease. Again, these vessels are often heavily calcified, mixed morphology. Thrombus is often a component of this, and therein lies the effectiveness of the SF device with active aspiration. So same basic techniques, 014 wire, 7 French sheath compatible. This is the shaft length of the SF device is a little bit longer than on the other devices, so you can clearly reach all the way down to the ankle and beyond if you need to. But beyond those issues, the technique is the same, slow, methodical advancement back and forth to debulk. And you'll see as you review these examples the effectiveness of this device. This is a multi-lesion anterior tibial artery that was treated effectively with the device. A very diffusely diseased segment, the G3 device was used. This is a patient that had a distal thrombotic occlusion that Malcolm Foster treated. This was approached with the JETSTREAM SF device distally, and you can see the excellent result in the far right panel. Complex chronic total occlusion of the distal popliteal artery extending into the anterior tibial artery, again, effectively recanalized and debulked with the G3 SF device. More complex anatomy, multivessel, posterior tib, and anterior tib effectively treated with the device. So as you can look through these, a variety of complex infrapopliteal disease segments, all of which responded very well with this device. So to summarize how this device can be integrated into your practice, this is a unique atherectomy thrombectomy device. It's currently approved for clinical use in infrainguinal occlusive disease. Its inherent properties of differential cutting, dynamic aspiration, and multiple cutter sizes confer safety and efficacy for a variety of disease locations and morphologies. It is effective in removing calcium, soft plaque, and thrombus with a reduced risk of distal embolization by virtue of its aspiration. The ultimate luminal gain that you achieve exceeds the size of the cutter alone. The real question is how to use this device beyond the indications anatomically. Do you use this as a standalone therapy? Do you integrate that with plain old balloon angioplasty? Or do some of the newer technologies have promise in terms of integrating this? Whether that's self-expanding stents without drug-coated self-expanding stents, or drug-eluting balloons. And we need further studies to really validate how we integrate this into that treatment. And the other indication that currently does not exist is the use of this device for in-stent restenosis, but there's a lot of excitement among early operators about the potential of this technology for treating in-stent restenosis, but currently that constitutes an off-label use. So I'll stop at this point. Be happy to entertain any questions that anybody might have. I want to, again, thank Bayer for sponsoring this, and we'll open it up to the audience for any questions.
Tom, you didn't mention it, so I'm assuming there's not been any instances where you have eccentric calcium, a lot of it, big, and non-calcified opposite wall. Have there been any instances in which you've seen a little leak or perforation through the non-calcified wall?
Yeah, that can happen. In the many patients that I've treated, I've had one or two patients where that's occurred. It's usually in a chronic total occlusion that we've recanalized, where we see that. Both of those patients were treated very effectively. That's why it's very important after the initial pass and the low profile to do a complete angiogram to assess that, because clearly when you increase the profile and put the blades up, there is the potential for disruption. There are some key feedback pieces of information that will sort of guide you as you're advancing, which potentially will prevent that from happening. The most important is the pitch of the device as you advance it. The patient will sometimes experience discomfort, so anytime they feel pain, whether or not you have a change in pitch or not, you should back off because you may be going deeper than you want. But in the two patients that I recall that we've had that simple balloon angioplasty sealed it, we've not had a single case where there's been complete loss of vessel integrity and tear in the vessel, small micropuncture, which was dealt with by balloon angioplasty. And in the two cases, rather than abandoning the technology completely, what we did is simply pass it beyond that area without spinning the device, dealt with that more locally, and then continued to debulk the long segment of disease. And it's worked out well. Mark?
Two technical questions. Number one, do you use a higher support wire or a 014 wire?
Yeah.
And the second is, I know it's off-label, but in the stenting, do you put a filter down or do you trust the aspiration?
The second part is for in-stent?
Do you put a filter down for an in-stent restenosis, or do you trust the aspiration?
Okay. So there are a variety of wires that you can use for this device. What you don't want to use is a hydrophilic wire, number one. You need an extra support guide wire, but it doesn't have to be, super stiff guide wire. I have no financial arrangement with Bayer. I tend to use the jet wire. I think it's a great wire. It's got a soft tip. It's got great support and body, and it really allows you to treat anywhere in the infrainguinal circulation. But, you can use any basic extra support wire, provided that it's non-hydrophilic. In terms of the second part, I've got to say at the outset, as I begin this discussion, that use of the device in stent is off-label. So just to clarify, but I have used it frequently for in-stent restenosis, and I think it's one of the best devices that we have at our disposal, recognizing it's off-label. I've not had a single incident where the device has, led to any trauma to the stent, or where the device has stalled or failed in the interstices of the stent. I do not use distal protection. The disease is more organized and less friable and lower risk, I think, of distal embolization. So the technique is the same, even if it's a CTO of a stent. Recanalize, basic angioplasty techniques, usually an 035 guide wire, exchange out for the 014 wire, and then begin to debulk. If it's really fibrotic, really firm, there have been a couple of patients where I've used the small device first as a pilot, kind of the rotablator technique, and use a step approach. A little bit more expensive, but it's highly effective in removing the disease. And therein, to me, lies its value. Now, other devices, other atherectomy devices are being evaluated, as you know, for in-stent restenosis. But in my initial experience with this device, it's proven to be very effective. SFA, popliteal, below the knee, it's been great. And I don't use distal protection.
Hi, Chief Shelgakar from Ann Arbor, Michigan. I want to ask you a question about the slides you put up about extending this device for osteal SFA and common femoral disease. Mm-hmm. And you made a very important comment about protecting that profunda. But I'm curious as to how you would do that. Most of the time the bulk in the common femoral artery is posterior. The anterior surface is usually okay. Mm-hmm. And then you have osteal disease. So when you do it surgically, you have to take great care to protect that profunda. and it's actually challenging doing it surgically. So you're doing the device in the common femoral artery, extending it on there. How are you protecting that ostium of the profunda?
Of the profunda? Mm-hmm. We have not, in terms of design. Don't put a second wire in. I mean, you don't want to do that. I guess we really sort of capitalize on the attributes of the device alone to minimize any compromise to the profunda. And we've done a fair amount of SFA origin as well as common femoral without any significant compromise to the profunda. We've not had to intervene in the profunda by virtue of doing the common femoral or the SFA origin.
Yeah, so you clearly are an expert at this, and you've done a lot, and you must have some area of expertise that many other interventionalists don't have. In my hospital, they've abandoned common femoral atherectomy because of embolization onto the profunda. And oftentimes, that's the first thing, oftentimes the common femoral disease extends significantly to the external iliac, so then you must also be doing a lot of external iliac atherectomy. See, one of the advantages with surgery is that you can get, you can lateralize the inguinal ligament, get up about 5 centimeters on the common,
Right.
on the external iliac, and actually debulk that whole area, as opposed to, so you must have to do atherectomy of the external iliac artery too as well.
Sort of at the transition into the common femoral, but I don't systematically debulk into the external. I tend to stent that with self-expanding stents.
So I guess I just wanted to make the point that I think that your local expertise should not be sort of expanded to everywhere else, because I think a lot of people don't have the expertise that you clearly have.
Yeah. Point well taken. You know, I think that there's no question the common femoral is a very difficult subset. But I think the point I would make, though, is I think that there is a predictability with this device by virtue of its design properties itself, rather than to some technical proficiency on my part. And I think, you know, I would not rely solely on the angiogram. I think that's the other point I would make. I tend to use intravascular ultrasound very liberally in my interventional practice, periphery as well as the coronary. And that, to me, is really a key point in using this device in terms of safety and defining efficacy. If you have any questions, I think your point's well taken. If you have any questions or concerns about potential compromise to the profunda or your ability to effectively debulk the common femoral, then I wouldn't do it. Dr. McNamara?
Oh, I have a question, but I was just thinking about that. You're actually truly removing, you're not pushing
Right.
the atheroma. The problems we've run into with profunda compromise is actually moving plaque,
Right.
either subintimally with the balloon angioplasty or physically forcing it with the other devices.
Yeah.
When you're looking in the trifurcation, Tom, do you, what's your indication or what holds you back from using this device on virtually any disease below the knee that's not short segment?
Yeah. Probably the most important issue is the anatomy, the extent of the distal disease, the clinical situation that you're dealing with, acute occlusion versus chronic, and you know the clinical situation in terms of critical limb ischemia. I guess to sort of make a generalizable statement about it, I think that I would tend to use more conservative debulking the more complex the disease is, especially in the early experience of operators. You know, start with something more focal in that disease location, become fairly comfortable with it, and then progress like anything into more complex subsets. But I think that by virtue of the smaller sizes, you can effectively use this even for complex trifurcation disease. But I think technique in that situation is paramount. Because if you have distal embolization in that situation, that's a lot more difficult to deal with and to chase. So start small, you know, slowly advance the device and let that device debulk and aspirate. And I think that you can stay out of trouble.
Is the use of the device reversible to the facility?
It's an improved device. Yeah, absolutely. Both as aspiration, both as atherectomy and thrombectomy, reimbursable. Good question. Any other comments, questions? Thank you all for your attendance. Appreciate it. If you have any questions, come on up in front too. Thank you.